Hello, everybody. I'm Dr. Tanu Singhal. I'm a consultant in pediatrics infectious disease at Kokilaben Dhirubhai Ambani Hospital, Mumbai. I have been taking care of patients with COVID 19 for the past 6 months, and I'm going to be talking to you about the post discharge care of children with COVID 19. COVID is a stressful experience for the child and the family. Hence, an important aspect of post discharge care is to reassure and allay the anxiety of parents. They need to be counseled about possible post discharge complications and what to monitor clinically. If any laboratory or radiologic investigations are needed, they need to be told about how to get them done. Questions related to medications and nutrition have to be addressed. In the Indian setting, food concerns are common. The parents have to be guided in this area. They have to be told about vaccinations which may need to be taken or those that are contraindicated in view of the treatment administered. Issues related to isolation of the child have also to be dealt with. This opportunity should be taken to explain briefly the nature of COVID 19 disease and how it affects children. They should also be told that both short term and long term outcome of COVID 19 in children are better than adults. They should be given clear directions about when to seek emergency care and the routine follow ups. In children with mild illness, no regular monitoring is needed. They should be asked to do a teleconsultation or physical consultation 2 weeks after the onset of the illness. Since the pediatric multisystem inflammatory syndrome may occur in children with mild COVID illness after 2 to 3 weeks, parents have to be told about this rare possibility and its symptoms, including fever, abdominal pain, rash, diarrhea, vomiting, and shock. Since some children with mild COVID may progress to respiratory complications such as pneumonia, parents should be asked to watch for any respiratory difficulty in the index case and seek medical help. Regular monitoring of oxygen saturation with a pulse oximeter is not needed in children with mild disease. On the other hand, children who have had moderate or severe COVID disease need better monitoring at home. These children are at risk for cardiorespiratory deterioration due to secondary bacterial infection, new viral infections, evolving fibrosis, and sometimes pulmonary thromboembolism. The child's respiratory rate needs to be monitored, and parents need to be told about the age-related cutoffs of respiratory rate. The saturation should be checked with a pulse oximeter twice a day, both at rest and after a 5-minute walk, for 1 to 2 weeks after discharge, or even longer as the need may be. The lowest acceptable saturation for that child should be told to the parents. Because some children with COVID go home with saturations of less than 95%. Parents or caregivers should also be asked to check their own saturations to make sure that any low saturation is not erroneous before they sound alarm bells. Since it is known that COVID can cause lung fibrosis, those children who have had evidence of pulmonary involvement, either in the form of tachypnea, hypoxia, or significant involvement on CT, should have their lung function monitored on follow-up. This is generally possible only for children older than 7 years who can do a spirometry. Spirometry should be done 2 weeks and 6 months after discharge. In children who have residual abnormalities after 6 months, spirometry may be repeated as per the need. Children with the pediatric multisystem inflammatory syndrome usually need more intense monitoring. They should be monitored clinically for return of fever, breathlessness, cold extremities. Some of them may need laboratory evaluations such as complete blood count, CRP, or ESR before the next follow-up. Echo may be needed at periodic intervals, especially for those children who had coronary artery dilatation and those who had reduced ejection fraction. Here, the advice of the treating team should be followed about the timing of the echo. Most children who have been treated for COVID don't need any medications. Advice about nutrition should be given, and some multivitamins, mineral supplements may be prescribed. This includes zinc, iron, or vitamin D. If antibiotics were given, then their course should be completed. Other discharge drugs should be continued. This may include corticosteroids in children with severe COVID and in children with PIMS. Anticoagulants, including low molecular weight heparin, may have to be given in those children who had documented thromboembolism in their hospital course and those who had the pediatric multisystem inflammatory syndrome. Aspirin may be needed in children with PIMS and coronary artery abnormalities. Some children may also need antacids, proton pump inhibitors, and antiemetics. Children getting admitted to hospital wards or intensive care units are often isolated from their family members and may experience considerable stress in COVID versus other severe illnesses. Some of these children may also have parents, grandparents, or siblings similarly sick. Hence, all children should be screened for psychological problems during follow up and consultation with a pediatric psychologist organized if necessary. Vaccination should be continued as per schedule. However, if the child received intravenous immunoglobulin for PIMS, then live vaccines, including MMR and chickenpox, should not be given for 9 months. If corticosteroids have been used for a period of more than 2 weeks, then live vaccines should be avoided for the next 1 month. If the child had severe lung involvement, then pneumococcal and influenza vaccination should be offered to the child on the first follow up. Prior receipt of IVIG or steroids does not interfere with killed or inactivated vaccine administration. Now, let us talk about the post discharge isolation of the child. There is new data which indicates that viable virus is not found in children with COVID 19 after 2 to 3 weeks of onset of symptoms. Hence, children who have been discharged home can be de isolated 7 days after coming home. A repeat negative swab is not required for de isolation. In fact, some people infected with COVID can have positive swabs for 3 months after infection, and these are just RNA sequences of the dead virus. However, children who are immunocompromised should ideally have a negative swab before de-isolating them. Children with PIMS do not normally need further isolation after discharge, as PIMS is a post-infectious syndrome and most children with PIMS are nasopharyngeal swab negative. So finally, coming to a summary of the post-discharge care, the good thing is that most children with COVID have mild disease, recover quickly without sequelae, and need no specific post-discharge medications or monitoring. However, children with severe COVID lung illness will need clinical monitoring, pulse oximetry, and lung function monitoring after discharge. Children with PIMS will need medications, lab monitoring, and echo as per protocol. Vaccination should be continued as per schedule with stress on flu and pneumococcal vaccination in children who have had COVID lung disease and taking into account IVIG and corticosteroid administration prior to giving live vaccines like MMR and chickenpox. Psychological support to the child and parents is paramount. Thank you.